Good afternoon, everybody, and welcome back. I trust you had a decent lunch. I certainly did. Right, this afternoon, the first session is going to contemplate a very important subject, and one which I think is going to become increasingly important. We're going to talk about sustainable dental practice, and we're very lucky to have Stephen Mulligan to come and address us. He's a GDP in Yorkshire and a clinical teacher in restorative dentistry at the University of Sheffield, which actually is the centre of the universe as far as dental learning is concerned. He works there within the academic unit of the restorative dentistry department, and for the last 7 years he's been researching this topic as part of a PhD programme. He's presented his work both nationally and internationally, been published in peer-reviewed journals, but far more important, has actually talked about this topic on the BBC documentary Inside Out. Grantham Scholar within the Grantham Institute of Sustainable Features, and has been jointly successful with his co-investigators in getting academic research grants totaling over 1.6 million. He was recently appointed to the Sustainability in Dentistry Task Team for the FDI Sustainability in Dentistry project, which aims to map out strategies and implement solutions to help reduce the environmental impact of the practice of dentistry and the dental interests. So, first of all, Stephen, over to you. Let's hear your presentation.
Thank you. Today, I would like to discuss the topic of sustainable general dentistry and provide some evidence-based ideas that can be incorporated into your everyday practice. I'm Steve Mulligan. For most of my working week, I'm a GDP. I also research sustainability in dentistry at the University of Sheffield. I begin with a disclaimer. I'm not perfect. I drive a car. I use central heating. I purchase unnecessary items. I try and purchase lower impact items. I try and spread a pro-environmental message in a non-partisan or preachy way so that individuals can make the changes they want to make. I'm a strong believer in the power of marginal gains. I think we can all make small changes to have big impacts. Iatrogenesis within dentistry is associated with inadvertent or unintentional harm or damage caused to the patient through carrying out treatment aimed at providing an improvement in health. An example would be extensive crown preparations without consideration of the pulp of the teeth. I want to ask the question, as dentists, have we been and are we continuing to cause environmental iatrogenesis? Through providing dental care, are we inadvertently or unknowingly creating negative environmental problems? Global temperatures are already 1 degree higher than pre-industrial levels. If we don't curb carbon emissions by 2050, the mean global temperature will be 1.5 degrees higher at best, and at worst 3 degrees. By the end of the century, temperatures could even reach 6 degrees higher. This doesn't seem like much, but bear in mind during the Paleocene-Eocene thermal maximum 56 million years ago, which saw a 5 to 8 degrees centigrade global average temperature rise across the event, the poles were free of ice caps, and palm trees and crocodiles lived above the Arctic Circle. Global climate change has been described as one of the biggest global threats to human health of the 21st century. Through the actions we carry out when providing dentistry, we use resources, emit carbon, and create waste. We help patients every day, but in doing so, we contribute to climate change. Climate change is intrinsically linked to health. It has been calculated that climate change already causes 150,000 additional deaths every year, and this will increase to 250,000 deaths between 2030 and 2050. In the UK, air pollution kills 40,000 people every year. Healthcare is identified as a major contributor to carbon dioxide emissions, and in the UK, this is estimated to account for about 5% of the national emissions. We are ethically bound as healthcare providers to consider the health of people and the planet, and we must first do no harm. We need to try to make dentistry sustainable to mitigate these impacts. So, how do we define sustainable dentistry? Simply put, we're trying to ensure that the care we provide today does not negatively impact the environment or prevents the provision of similar care to future generations. Throughout the next 20 minutes or so, I would like to present an overview of the current knowledge base on sustainable dentistry and give some recommendations of what can be done to mitigate negative impacts. As I mentioned, I am a jobbing GDP, but I also have an academic side. So to find out what we currently know about sustainability in dentistry, I did a good old-fashioned literature review, or more specifically, a scoping review. A scoping review is used to map the body of knowledge in a chosen field, in this example, within sustainable dentistry. The scoping review was conducted for all published literature in the English language that addressed this topic up until the 31st of April 2021. At the end of this review, 128 records were deemed suitable for inclusion. The scoping review identified these 8 common themes. The 4 R's: environmental impacts, policy and guidelines, biomedical waste management, plastics including single-use plastics, materials, procurement, research and education. I will now go through each of these themes, giving an overview of the major issues in the literature and recommendations for sustainable practice. The 4 R's. Classically, the 3 R's of reduce, reuse and recycle have been used to suggest environmentally friendly behavior changes. Over time, up to 4 additional R's have been added. For example, refuse, as in refuse to purchase unsustainable products, and repurpose, as in repurposing items for different uses. In the literature regarding dental sustainability, it was apparent that 4 R's were most suitable: reduce, reuse, recycle, and rethink. Reduction is a strategy that can be applied, for example, in the use of materials, associated packaging, and indirectly carbon emissions. We can plan procedures to cut down on unnecessary item use. An example would be putting prophy paste on the back of a glove or in a tray rather than in a disposable plastic Dappens pot. 33% of the waste generated in the dental surgery is packaging. Therefore, we should try to purchase products with minimal packaging. Finally, go digital, and ideally paperless, to reduce environmental impact. Reuse. Within the setting of the dental surgery, it is difficult or even impossible to implement policies of reuse for cross-infection reasons, ease of use, and perceived costs. However, reusable gowns have a 2 to 3-fold reduction in terms of energy, water, and carbon emissions, and a 7-fold reduction in waste. In these COVID-stricken times, the use of these gowns has been highlighted. We can also consider wipeable patient bibs and face shields to be sustainable. Finally, there was evidence that reusable cassette trays were more environmentally sustainable than disposable sterile packaging. Recycling. When we discuss recycling, there is potential to separate plastic and paper from sterile wrapping in order to recycle it. Effective separation of sterile wrapping before contamination could save up to 5 kilograms of waste per week. If sterile wrapping was disposed of as recyclable waste instead of as clinical waste, there would be an approximate reduction of around half a ton of greenhouse gases per year per practice. There is also an opportunity to identify and use pre-existing community recycling programs to recycle paper and plastic halves of autoclavable bags and packaging. By recycling office waste, such as plastics, paper, and medical shredding, toner and inkjet cartridges, there are also cost savings for the practice. Finally, provide staff facilities to recycle their waste. This imparts an environmentally responsible ethos within the practice. Rethink. The best example of rethinking with regards to sustainable practice involves looking at the supply chain of materials and goods that are used on a day-to-day basis in a dental practice. As a practice, goods or materials are bought, used, and disposed of in a linear fashion. But what if we could create a circular economy where materials can be reduced, reused, or recycled? Here is a schematic of a linear dental supply chain compared to a circular one. The major difference you can see is that at the waste collection point in the green circular economy model, the non-contaminated waste is returned to the manufacturers or packaging sections in the supply chain. This would allow huge reductions in the needless incineration of potentially recyclable materials. But it needs stakeholder involvement, Namely, the dental practices have to separate the packaging, the waste collection services have to collect the packaging, and the manufacturers and packaging companies need to have systems in place to reuse or recycle the materials. As a profession, we should lobby for incorporating circular economies in this fashion. Environmental impacts. The major environmental impacts of dentistry in the literature stem from direct air pollution from travel and incineration of biomedical waste, energy use with associated carbon impacts, water consumption, and carbon releases from multiple sources. We also need to include the other major greenhouse gas associated with dentistry, nitrous oxide for sedation. From this pie chart, it can be seen that over 60% of carbon emissions associated with dentistry comes from patient and staff travel. Dental-associated travel negatively affects air quality, releasing over 443 tons of nitrogen oxides and 22 tons of particulate matter annually. In addition, incineration of biomedical waste also contributes to air pollution. I feel I do not have to remind a dental audience of the intensive energy and water requirements that our profession has, especially those paying the bills. From the literature, it was found that the energy use of buildings makes up 15% of the carbon footprint of primary dental care. The annual carbon footprint of NHS dental electricity and gas is about 14% of the total carbon footprint of NHS dental services in England. Interestingly, older, smaller clinics with no air conditioning and fewer meeting rooms generated lower carbon footprints than newer clinics, suggesting that new buildings are not necessarily more energy efficient. The European Dental Association reports that dental offices consume 57,000 gallons of water a year, with an average water consumption estimated at around 33,000 litres per surgery per year. Here are some recommendations relating to tackling the issues raised on the last slide. A common theme that intertwines throughout this scoping review is that of reduction, and in the context of direct environmental pollution caused by dentistry, it is the strategy of choice to employ. If we can prevent dental disease prevalence, we reduce the need for attendance and the number of interventions. This can be done by following all the methods we currently use, such as fluoride application and focused oral hygiene education. As highlighted on the previous slide, the impact of travelling on carbon emissions associated with dentistry is an obvious hotspot to address. A 5% shift to walking and cycling by staff commuting to work would reduce carbon and air pollutant emissions by over 6 tons of nitrogen oxide and half a ton of particulate matter. The dental profession should focus carbon emission reduction strategies on staff travel. Accordingly, electric vehicles are promoted. Employers should further promote and incentivise active travel among staff, as this has additional health benefits. Active staff are healthier, usually happier, and take fewer days off. Other strategies that are widely advocated include the encouragement of public transport and car sharing, combining patient appointments and providing multiple procedures in one visit. Also, a greater use of technologies such as CAD/CAM and intraoral scanning will reduce the number of appointments and transport to laboratories. Seeing families in one visit or a family appointment is a good method of being efficient and sustainable. It is better to purchase in larger bulk deliveries. The use of telecommunication should be enhanced for all administrative logistics and even for remote clinical consultations when appropriate. Programs such as Child Smile, where only the dental team travels, reduce travel emissions, as there are fewer people travelling to provide care, and this also applies to attending to patients at care homes. Key to success is staff and patient engagement, and this should be driven through a series of proactive approaches such as staff training, increasing awareness, use of e-dentistry resources, online videos, sustainability notices with photographs and leaflets, and promotion through social media. This is good because patients will see this, and this can be a real practice builder. This can be achieved as well by designating a lead sustainability officer in the practice, or a sustainability working group to try and embed these ideas. It is essential that sustainability practice, policies and procedures have effective action plans and realistic targets so that they become part of day-to-day running of the practice. Policy and guidelines. In the literature, there was a general consensus that there needs to be a closer, more effective and more pragmatic alignment of two very divergent regulatory frameworks. That of cross-infection control, and environmental stewardship. There also appears to be a lack of engagement with team members of the dental team, with nurses and hygiene therapists not being involved in the discussion on sustainability. So recommendations to address these issues include better representation of sustainability promotion at policymaker level all the way to local level. This includes LDC committees. All staff should be given the opportunity to help to shape a sustainable practice. However, manufacturers of materials need to be more responsible and transparent so that sustainable purchasing is easier. Finally, financial incentives should be made to promote sustainable practice. Biomedical waste management. The issues highlighted in the literature with regards to biomedical waste were ineffective segregation of waste and medicine waste, especially antibiotics. Effective segregation enables recycling of household waste, significantly reduces the burden of contaminated waste, and avoids accidental harm, for example needle sticks. Poor waste segregation leads to non-clinical waste being disposed of in the clinical waste stream, increasing the cost of the practice and potential harm to the environment from incineration. Paper is a huge source of waste in a dental practice, and it is easily segregated and recycled. Antibiotics are commonly administered within dentistry and have a negative impact as they can enter wastewater when inappropriately disposed of. A reduction approach is the most widely advocated management strategy for medical waste. Effective management strategies to reduce the impact of this include reduction of prescribing antibiotics. Only prescribe the required amount and encourage patients to return unused medication to the pharmacy for safe disposal and not down the sink or in the toilet. Waste packaging of medication can be recycled using blister pack return schemes. Educating staff on appropriate segregation, especially paper waste from packaging, for example, is easily achievable and impactful. Single-use plastics. Plastic, and in particular single-use plastics, form an essential and indispensable part of current healthcare provision at all levels and in all clinical environments. Within dentistry, SUPs are used in the form of PPE, gloves, bibs, aprons and masks, sundry clinical items such as aspirator tips, tray liners, cups for rinsing and handle covers, and also in the form of material packaging. COVID-19 has had a huge impact on the amount of SUPs used in dentistry. This table depicts official Department of Health and Social Care statistics, which show the surprising amount of PPE used prior to COVID-19 and the astronomical amount used during the pandemic. How do you solve an issue like single-use plastics? I was working on this tricky subject with some Sheffield University colleagues in the heady days of 2019, prior to the pandemic. We were already trying to better understand and implement a circular economy for medical plastics, and the reality is this is incredibly hard to do. Disposable examination gloves of the type used in the dental profession form a large part of the waste stream. We use nitrile gloves predominantly due to allergenic issues. However, latex is an environmentally sustainable material, which is also naturally biodegradable. The production process for the raw materials for latex gloves is drastically less energy intensive than nitrile gloves. We need the best of both, a non-allergenic biodegradable material with low energy manufacturing requirements. This requires more research. Alternative materials have been developed for other SUP applications. One interesting one was polyvinyl alcohol used by one UK company for manufacturing biodegradable bags, plastic coverings and aprons. The main way to reduce SUP use is to minimize SUPs as much as possible, for example in packaging. In this context, manufacturers and distributors should be encouraged to concentrate on optimizing and reducing packaging so that dentists purchasing these items can choose environmentally responsible suppliers. Materials. There is no such thing as an environmentally friendly dental material, but some are much worse than others. Dental materials have a high pollution impact from all levels of the supply chain, including synthesis of their raw materials, manufacturing, distribution, procurement, clinical use, and ultimately waste management. For many decades, the dental environmental spotlight was focused on dental amalgam, A greater appreciation and understanding of the pollutant potential of other dental materials should drive further research in this field. Amalgam contains mercury. This gets into the environment in a number of ways and it bioaccumulates. As a profession, dentistry has to stop using dental amalgam on these environmental grounds. Legislation and availability will probably bring this about in the form of recommendations from the Minamata Treaty and the fact that companies such as Dentsply have stopped producing this material. Other materials in dentistry with environmental impacts include nitrous oxide, which is around 298 times worse as a greenhouse gas when compared to carbon dioxide, gypsum waste, which can form hydrogen sulfide gas when disposed of in landfill, and resin-based composite, which contains plastic monomers and bisphenol A, which are released into the environment in a variety of pollution pathways. Recommendations based on the issues associated with dental materials are: regarding dental amalgam, we have to reduce the amount we currently use, and on the basis of environmental harm, move to eliminate its use completely. I have been in clinical situations myself where it is still the best material for use, that subgingival restoration in a difficult to access position. And my only advice is currently you should only use it sparingly and when required. Nitrous oxide requires the use of dynamic scavenging systems to prevent its release. Gypsum should be disposed of responsibly through appropriate waste segregation. And in addition, intraoral scanners will reduce the amount that's generated. Finally, resin-based composite materials that are bisphenol A free, or more specifically bis-GMA free, should be considered. Sustainable procurement, when applied to dentistry, is the practice by which the dental surgery addresses environmental and social or ethical considerations when they purchase goods or services. Procurement is a major hotspot in sustainability, noted as the second highest contributor of the UK NHS dentistry's carbon footprint. Extensive and complex care plans requiring multiple appointments are very resource intensive. This highlights the need to promote prevention as the most effective way of managing this pollution burden. The limited supply of sustainable products on the market and the user convenience of some products such as disposable gowns overrides the desire for more sustainable options. Recommendations for sustainable procurement include better logistics, which might include consolidation of deliveries. Purchasers should be asking the suppliers for eco-friendly dental options to stimulate manufacturers to produce these products. Office supplies and paper use are a significant hotspot, as previously highlighted, and easily achievable to address. A professional move towards a more sustainable dental practice will embed core sustainability values and consequently put pressure on suppliers to engage in a similar manner. Effective internal stock management in the dental practice is key to sustainable procurement. There is a need to regularly order stock to check for expiry dates and monitor usage. Dentists are becoming more aware of their influence on the environment through providing oral health care, but they don't know how to engage, or indeed if it would make any difference. Therefore, there is a need to investigate the complex internal drivers and external forces that influence sustainability, including the behaviour of each stakeholder, including dentists, and that of the supply chain as a whole. High-quality life cycle analyses are required to identify hotspots in the supply chain, dental products, procedures and care provision, so that evidence-based changes can be advised and made. Funding should be focused to support areas where evidence is lacking and to support innovation. Sustainability is on the curriculum for medical students, and it needs to form a larger part of the dental curriculum. It's actually now a major topic of discussion in the Association of Dental Education in Europe, as evidenced by a recent consensus paper that suggests 8 pillars as a framework to promote best practice for the teaching of sustainability in dentistry at undergraduate level. There is also a recognition of the need to involve and engage with professions complementary to dentistry, such as oral healthcare workers, hygienists and therapists. Awareness training should recognise that single-use plastics and disposable items have a high environmental price, and the dental team should be educated in best sustainable practice for waste management. Patients should be educated to adopt environmentally sustainable practices, such as turning the tap up when brushing teeth, and, most importantly, the benefits of good oral health through preventive regimes to reduce the number and complexity of interventions over their lifetime. We're coming to the end of my presentation, and there's been a lot of information over this whistle-stop tour of sustainability, but I want to end with one main message. This infographic has been developed by me and some colleagues working with the FDI. What it shows is that by integrating good quality preventive care, by all the ways we currently employ, operative care, which basically means doing good dentistry, good integrated care, which means involving the patient and the other members of the dental team, and giving patients ownership, and us clinicians having ownership of the care we provide, that we can become sustainable. This is stuff we can do tomorrow, which will give immediate and longer-term sustainable outcomes. These 4 pillars of good oral health care provision are good for the patient, good for clinicians, and good for the environment. Please visit the FDI Sustainability in Dentistry Project webpage for more details, or feel free to get in touch with me via LinkedIn or through the University of Sheffield. Thanks for listening. Hello. Today I would like...
Oh, I thought you were going to do it all again for a minute then, Steve. And it would have been very well received, obviously. Lots of pearls of wisdom there. As you might have imagined, you have scattered a few questions or stimulated a few questions that are out there. One of which is on the political side of things, asking whether academic dentists with the specialist interests you have any connection with the policymakers writing HTMO 105, which I think a number of colleagues feel is actually stimulating a lot of unnecessary energy use to defeat an enemy that doesn't really exist, i.e. the prions causing new variant CJD.
Yeah, I mean, we have occasionally been trying to push out to policymakers in that respect, but HTMO 105 is embedded within dentistry, and we are looking to try and involve ourselves more with recommendations based upon evidence base. I know, looking at the chat board, that a lot of these were a lot of issues that came up. It's controversial in some respects, because things like amalgam use and the fact that we use so much plastic in dentistry are almost unavoidable sort of topics at the moment. But hopefully, by developing better materials that have got amalgam, and we have got other ways of incorporating single-use plastic use into a more sustainable sort of circular economy, we can actually sort of involve ourselves more with HTMO 105 rewrites and ensure that we can be more sustainable in that respect.
Okay, next question from Russell Gidney in Wales, just asking, on balance, what's the relative environmental impact of composites compared to amalgam, as best we can estimate at the moment?
Very difficult to do. Ultimately, I'm a dentist. I've been in clinical practice for 15 years, and the amalgams that I put in 15 years ago are still going nice and well. There's been a lot of studies that compare the clinical effectiveness of dental amalgam versus resin-based composite. But like any material, if it's placed well, resin-based composite can actually last a good length of time, because the carbon impact of material use really comes down to its replacement and how often that happens. So there's a mention on the chat board there about, well, resin-based composites take longer to be placed. Resin-based composites are actually more technically sensitive, shall we say. And some of the manufacturers are coming up with easier, quicker ways to put resin-based composite in, but this is a burgeoning field, and we don't have the 100 years of evidence base that amalgam is a good material in the posterior dentition. So there is skepticism that, you know, using these modern materials will actually be beneficial, but we don't have the evidence base of amalgam. So I think we have to take some strides to make sure the dentistry we do is carefully done. We are going to have to put these materials in and hope that they are as well performing as a dental amalgam material. Remember that resin-based composite is not an inert material in itself. It is plastic-based. It comes in, you know, multiple plastic containers. It's got lots of additional requirements, like within packaging, and you know, to be honest, to put resin-based composite well, you need more materials and more time and more funding I'm being honest in that respect. And if we are going to be told to be using dental amalgam less and resin-based composite more, then this is something that we do need to speak to with regards to central government, that UDA systems don't really work too well for us to be putting in resin-based composite to a higher level in sort of that environment. It's a tough call, because some people are saying, well, I can put resin-based composite in very quickly, just as quickly as amalgam, and it will last just as long. I'm a clinician that does a lot of resin-based composite, and there's the mention here about using extrudable tubes rather than compules. That's a good idea. That does have less of a carbon impact with regards to the material use. But yeah, I think these are all things that we all need to be sort of questioning and discussing and asking, you know, if we are going to be putting good quality dentistry into patients' mouths that lasts a long time, we do need more time, we need more money, we need more funding for a public health service model, which is controversial, but it comes down to we'll get out for now in Yorkshire.
Yeah, I rather wish we'd had you on earlier with the Chief Dental Officer in that respect. One final question, I'm going to have to make it the final one because of the timing. Willie Sidhu's just asking if you feel that we might actually go back to not wearing gloves for some particular procedures because of their impact.
Well, no. And I mean, to be honest, it really came quite interesting in the research regarding latex use, because I saw Roz nodding on, I can see her on my screen with latex. I mean, the number of people actually allergic to latex in the general population is around 3 to 5%. And the number of sort of professionals who use latex gloves is, I think, less than 10%. So 90% of the working profession could use a material that is actually 10 times less carbon intensive. And obviously, we've taken the fact that latex can have allergenic issues and taken it to the nth degree, which is what HTMO5 and a lot of things like that do. They just look at the worst case scenario and extrapolate from there, often to the negative impacts upon things like environmental harm. So we'll never go back to wearing no gloves. We like I said in the presentation, we need something that is less energy intensive than nitrile and not dependent upon the oil industry, ideally. And we were looking to actually, in the BBC documentary, we were trying to work with a plastics professor on how we could actually legitimately collect soiled nitrile gloves, put them into a reuse system where they're not necessarily burned or stuck in landfill. They could perhaps be used for filling road defects or building park benches, and through the process of reuse, render them completely safe and not in any way pass on any harmful things. But yeah, it's a huge question. I've kind of given you everything on sustainability in 26 minutes, and I could have talked for a lot longer on every topic.
I'm sure. Well, I'm going to thank you for your input. That's very informative. And as I said, this is going to be something that's going to run and run. This is just the opening salvo. Unfortunately, the clock's against us, so I'll have to thank you for that. I take it colleagues with a particular interest could contact you at the university and just take things further should they wish so to do.
Of course.
All right. Well, in that case, I have to tell everybody it's now time that we moved on to the elections. Of course, often the most thrilling part of our conference. Please remember that voting here is a little different in that the GDPC members are allowed to vote as well. And we will start with chair-elect for conference. This isn't for next year. This is for 2023, of course. This is we always do this 2 years in advance. We have two candidates, Aggie and Mark, and we're going to hear an election address from each of them, just straight one after the other, and then we'll vote. Could we have the first video, please?
Why vote for me? Just for 1 year, could we focus on what patients want and need from us, from the state, from the NHS? I'm unashamedly patient-focused. I would like us to hear and construct a different narrative where we advocate on behalf of patients. The public wants us and needs us. Look at the queues of the 90s to be on a routine care list. Look at the influx of MP letters to NHS England during the pandemic, pushing for urgent care. I want to focus on the good, to share it and amplify it. The things we do to help people. The theme of the conference would elevate the day-to-day dentistry that consistently makes a difference to patients. We help people out of pain, deliver healthcare to huge numbers. We help people to eat and smile. This is not the healthcare that gets much positive media attention. It's not the Instagram feeds. It's the bread and butter work that serves generations. I believe we make a big difference to people, and just look at what happens if we're not there. Look at the majority of reviews about dentistry. Once we're seen, we're consistently valued by patients. But funding in England has gradually eroded, and we must not allow that to continue. We consistently show we can deliver despite limitations. I think we should examine our core beliefs. What's the bottom line here? Why the NHS needs dentistry, what we bring. Could this be the theme of the conference? Would you want to attend it? Best of luck to my learned colleague from North Yorkshire. I'm looking forward to a live conference, whoever wins the election here. Thank you for your time.
Good afternoon, conference. I hope it's been an enjoyable conference so far. And to start with, I'd like to thank Aggie for also standing. And the good news for conferences, I'm certain that 2023 will be in safe hands, whatever the result. For those of you who don't know me, my name is Mark Green, and I qualified from Leeds in 1995. And I've lived and worked in North Yorkshire mainly as an NHS dentist since then. I've long been involved in LDCs, following the significant footsteps of Richard Ems and the legendary John Renshaw. And I can well remember both these guys dragging me around LDC Conference, telling me on many, many occasions how important it was. Obviously, to a 20-something-year-old, the significance was slightly lost on me. However, the importance of conference very quickly started to show. The debates and motions are most passionately presented by the proposer and supporters, and equally countered and argued against by those who saw issues with the motions. These debates are the heart of LDC Conference, and that's what allows for a common way forward to be found. It is often said, if you have one patient and 10 dentists, you end up with 10 different treatment plans. Well, that same principle applies when you ask the profession, what should an NHS contract look like? Obviously, if we stand divided, that is where weaknesses can be exploited by those wanting to exploit them. And that is where I see conference can play a massive part. However, another hugely important role of conference is to build relationships, nurturing the next generation to be engaging in the future of their profession, to challenge the direction of travel, not just to accept things as they are. It is vital that this ability to be a thorn in the side is maintained. I'm hoping this conference is the last virtual one, and there is no way criticism of today's and last year's, as they've been vitally important in driving the debate. But that missing piece of human interaction of actually being there cannot be replicated by virtual means. So in summary, I feel I'm at the perfect stage in my professional life to take on the mantle of chair of conference. I have many years' experience, yet I still have enough skin in the game to make me relevant. Should you choose to put your trust in me, then I can assure you that I'll give it my best shot at making 2023 a reet good one. Thank you very much for listening.
Right then, conference. It is now time to cast your votes. You've heard from the two candidates. The voting is now open. Conference that your chair year after next will be Mark Green from North Yorkshire. Congratulations, Mark. I look forward to attending. Thank you. Right, the next election, this isn't going to take quite so long, is that for the Honorary Treasurer of Conference. Pete Hodkinson, who's doing the job excellently at the moment, has agreed to let his name go forward. He is therefore elect unopposed. Similarly, The two honorary auditors to conference, currently Bruce Porteous and Jonathan Randall, have agreed to carry on. They're elected unopposed. Finally, we have the election for one representative to GDPC. That is the aforementioned Aggie Tarnowski, who again is elected unopposed. And one representative to the Conference Agenda Committee. We have one candidate, Russell Gidney, who is elected unopposed. One representative to the Board of Managers of the British Dental Guild. One candidate, Howard Jones, who is elected unopposed. And that, I'm delighted to say, finishes the elections for this year. Congratulations to Mark. I look forward to working with you in the future. Now, the next section we have is perhaps the most important aspect of professional practice at the moment. That's looking after the dental workforce, the mental health and wellness. We have Ros McMullen, the immediate president of the BDA, an advocate of wellbeing in dentistry, to speak to us. Ros is a retired consultant orthodontist, chair of probing stress in dentistry in Northern Ireland, and the immediate past president of the BDA. She established the probing stress in dentistry, which works to raise the awareness of mental well-being in the dental workforce in Northern Ireland, and to establish a network of mental health first aiders to support and signpost dental teams who are experiencing difficulty. Ros was one of the collaborators which produced and maintains the resource www.supportfordentalteams.org, and has also worked with the DPA to produce the framework and supporting mental health wellness leads in the dental workplace. And we're going to hear more about that today. Welcome, Ros. Over to you.
Thank you very much. Thank you, Chair. I hope you can hear me.
We can, fine.
Great, and you can see my slides.
Yes.
Great. Thank you for having me. Wonderful. Congratulations on a wonderful conference so far. Really very telling subjects have been discussed, and nonetheless for this. And thank you for giving me the opportunity to present. And for once in my life, I'm not talking about stress or well-being or mental health issues. I'm talking about wellness. And how wonderful is that? Because we all need to do the prevention. And we're talking about early intervention and safe signposting in the dental workplace. And this is for all dental workplaces. So this framework that helps the teams, dental teams, put mental health wellness into their settings is composed of an awful lot of people. And as you can see, I'm the token dentist. There's very much the Dental Professional Alliance, comprising of all the dental team, representatives from the whole dental team, and I probably do the least amount of work of all. It's been co-produced by these people and with the help and support and professional endorsement of Prof. Tim Newton, as a Professor of Psychology at King's. So what's it all about? And you can see in the bottom of my slide, hopefully, although maybe the technology is hiding it, which I'll unhide it, the mental health working group is www.whmd.org. Oh dear, I can't go back again. Hopefully some of you have got online. And when you go online, you can download this framework. And this framework has been co-produced to be used in the workplace, all workplaces, not just general dental practice, but community, hospital, and even those people who are maybe not working in clinical settings. Now, for many of us who have young people or people in other jobs, you will know that mental health wellness is being put at the centre of their workplace too. And this was following a directive of the Health and Safety Executive some years ago. And through that, there have been a lot of mental health champions, as they've been called, placed in workplaces. And what can these mental health champions do? Well, they can frame well-being within the setting. They can act as prevention, so they can put prevention means in place by having safe places where people could go, be a listening ear to promote conversations, safe conversations in safe places when needed, but also to have resources around the workplace where people can access and get help. Some simple things like saying at lunchtime, right, we're going for a walk. No, Roz, you're not going to look at your emails. You're going to go for a walk with the rest of us, and you're going to take some time out and take a little bit of air. So it's about the prevention in the workplace. It's about mental health awareness for the whole team, for all team members, and prioritising that. It's about identifying and training a champion, but in the workplace, the DPA rightly feel that should be called a lead, because we're used to leads in the dental workplace. We're used to resuscitation leads, we're used to cross-infection leads. So it's about a mental health wellness lead, and what does that look like? And I'll talk about that in a little minute. But the whole point is early intervention and safe signposting for the whole team. And of course, the opportunity to reach out to the community. We in the dental workplace have a much greater footfall than even our medical colleagues. And we are seeing the well of our community, the well people, or so-called well, and we are the ones who could recognise that some of them are in distress. So why would we do it? Well, we do know that there's a strong link between well-being and patient safety. Well, we don't know actually in dentistry. I'd advise you to go onto the GDC website. They've actually recently published a rapid review done by Plymouth and Southampton universities and the Peninsula Dental School on what we know about well-being and the dental teams in the last 14 years. And in fact, outside dentists, we know very, very little. We know very little about the well-being of the remainder of the dental team, which is something we need to take on board. But we do know that there's a great link between patient safety and our medical colleagues, and the assumption would be that there's something similar. And a sense would tell us that when we are stressed, we maybe just don't make as good decisions as when we're not. It is very much in the leadership domain. It links very much with the key messages of all of the NHS or NHS improvement in all 4 countries about the 3 main topics of conversation, supportive and compassionate leadership, and mental health first aid champions. It actually formalises what many of you do already. Many of you do offer a very supportive environment for your teams, and this really only formalises that. It gives you an opportunity to take the framework and adjust it to what's suitable for your workplace. It is about training and staff development, of course, and support for the team and support for your staff. I've said that we know very little about the stress and well-being of DCPs in evidence base, but we do know in our workplaces that when our team members are stressed, it certainly impacts upon us and the care and the empathy that we can give. We need to learn more about that. Of course, COVID, as with many things, has spotlighted it, but it has been there before and it will be there when COVID goes. But COVID has been certainly an opportunity. It's about putting well-being at the centre of the team, looking after the team, valuing the workforce, patient safety, what we've been talking an awful lot about today, recruitment and retention, reaching out to our community, and of course facilitating networks. And there's a lot about that with our medical colleagues. So many of our medical practices in our local medical practices will have a well-being lead there too. And to develop those links and be able to liaise across and say that you're a little bit concerned about Mrs. So-and-so who was in today and you had a word with her, was she okay? And asked her to contact you. Hopefully she'll reach out. Not every workplace will need it. Many workplaces already have well-being leads within them, particularly in secondary care. So it's about risk assessing, and the document itself gives you some guidance on how you might risk assess your workplace to the need. It's about mental health awareness training for all team members. That's readily available. It's free through an awful lot of the mental health charities, but also the BDA CPD Hub offer a 2-hour course for all team members. You don't have to be a BDA member and you don't have to be a dentist to access that training. And we're suggesting that all team members do have that mental health awareness training. It gives a good footing for the workplace. For the mental health wellness lead, we're suggesting a competency-based mental health first aid training which has to be the competency-based one, because that allows for safe intervention and safe signposting, allows for the mental health wellness lead to learn about working within their competencies and within their boundaries. I've put suicide awareness training there. The mental health first aid training, by the way, is available by the Deanery in Northern Ireland. It is available through some of the public health bodies. In fact, through COVID, it's been available in the public health bodies in all 4 countries. It's hard to get access to, and some of the mental health charities, again, carry it. Suicide awareness training is a little more difficult to access at the moment because it does have to be a facilitated training program within 3 to 4 hours because of the sensitivity of the training, and that's difficult to develop online. So once the team, the workplace, decides to put this framework in action, and you get your risk assessment done and your teamwork up to speed, then you can sign up to a charter and put your own principles. So again, this is a bottom-up approach. This is about something that you can take into your workplace and adapt for your needs. We did put out a call to action, and I'm delighted to say this is not an exclusive list of those people who have come forwards and given statements of support, which is wonderful to see, and that's all available on the website. So what's the next steps? Well, we're looking for an early adopters group, and that's not just dental workplaces. We're looking for technicians as well. We're looking for 12 to 16 UK workplaces, which we can help us as an early adopters group as to how they have implemented the framework and improvements that can be made. There is talk about an more evidence-based evaluation programme, both from the framework point of view, from how easy it was to implement, and of course the effectiveness, and we're collaborating at the moment around that. And then we're looking to learn about the possibility of cluster and peer group and support networks. I want to thank you on behalf of the chairs and the members of the DPA, particularly Fiona Elwood, who's driven this project forward. So I really feel a bit of a fraud standing up here on the stage and talking to you about this, because I've probably done the least amount of work. But the work from the DPA has been phenomenal, and we do welcome any feedback. And I'm happy to take any questions.
Right. Thank you for that, Ros. And I'm delighted that this sort of work is going on and that people are volunteering. One question I've had is, how do people get in touch with support for dental teams? I presume that's just through the website, is it?
Yes, so support for dental teams does have, and I'm just struggling with the technology to get you back on my screen again. There you are. How are you? Yes, so supportfordentalteams.org is a separate group. It's a collaborative group of individuals who've put together a set of resources on this website and have agreed to keep on that work and keep updating it. There is a feedback form on supportfordentalteams.org where we will accept all feedback and groups that we may have missed, and we act on that. We're actually acting on the moment to produce some menopausal resources or resources for menopausal ladies on it. So please visit it. It's, again, downloadable, printable in black and white, something that you can print off and put in your staff room for people to lift up and read and use.
Thank you very much. And a question from Mark Woodger, who's Mid Mersey, LDC. Mental health is appearing in more and more performance cases. How do we show the regulators that the pressures we work under need to be considered more?
Yeah, and this is a very important point, Mark, and thank you for raising it, because as many of you are aware, there is a consultation out there at the moment on regulation to look at all 9 regulatory bodies and how the principles around that. And one of those outcomes of that could be that we actually lose what is one of the few good things we have in the GDC, and that's how they look after health cases, where we don't necessarily look on the health issue as a performance issue. And I feel very strongly about this, that people who have the spotlight of the regulator on them because of their health issues, they need to be treated with as anybody with any illness, with care, compassion, and empathy, in a way to help them be better and return to full practice, which many can and do achieve. So I feel very strongly about that, and I urge you to look on that consultation and to feed back to that. I think it is really important that although we know that mental health illness does impact upon competency, it's an important place to put your hand up early and go to a safe, confidential space. Practitioner health is now available to all dentists in England and Scotland. And by putting your hand up to them, you do not necessarily have to have your involvement of your regulator.
Thank you very much, Ros. I'm afraid time's against us. We're going to have to wrap it up there, but I'm delighted you're able to come and speak and impart those pearls of wisdom. They really are very important and very important take-home messages there. Thank you.
Well, thank you again for having me, and I hope people visit the website and think about implementing them within their workplaces. Thank you.
Will do. Right, we're now going to move to an extremely short break. It is literally going to just be time for a comfort break and back, and then we'll be starting motions again. I'm going to do that at 15:10, our scheduled time. Thank you. Sorry, we can.